Well, welcome to MS Connect 2021. And for those of you in the West Coast, thanks for getting up early to join us this morning. Hi, my name is Rob Maservi, and I'm speaking to you from Pickering, Ontario, which is a little north and east of Toronto. I became involved with the MS Society about 25 years ago when my sister was diagnosed with MS. I've volunteered since, including as an MS chair in Community Ontario, and as a Peterborough, Ontario chapter chair. I'm currently serving on the Central Canada Division Council as the co-lead of research programs and services. I'm honored to be your host for today's session. MS Connect is one of my favorite events. I had the privilege to be the MC for the 2019 MS Connects event held in Ottawa at the Infinity Conference Center. We had about 230 participants for that fall session. It was equally as good as the one that we're currently holding this spring. We might not be able to meet in person this year, but I'm very glad that we're able to connect with you online. With MS Awareness Month about to kick off on May the 1st, I'd personally like to thank each of you for taking the time to learn from these healthcare professionals and researchers who are committed to helping others. In Canada, we have some of the most exciting and innovative research underway in the world, and it's moving us closer to a world free of MS. The past year has definitely put a spotlight on healthcare equity and the research gaps within populations that have all too often been overlooked. I'm looking forward to hearing from Dr. Dalia Rotstein this morning about her study of MS in immigrants and the effect of the Canadian environment on the risk of developing MS. Her results can help us better understand MS risk factors and how to deliver quality healthcare for people with MS across the country. Before I introduce our speaker today, please allow me to share just a few housekeeping details, okay? Questions can be typed in the question box at any time throughout the session. That's the black box towards the bottom of your screen. Join the online conversation and share your favorite moments from today's session by posting on Twitter using the hashtag MSConnect. Make your voice heard and respond to our daily poll on our Twitter page at MS Society Canada. Now, just mention also the session is being recorded and will be shared at msconnect.ca. So I am now pleased to introduce Dr. Dalia Rotstein, who is a neurologist and assistant professor of medicine at the University of Toronto. She works at St. Michael's Hospital in Toronto, where her focus is on treating multiple sclerosis and other demyelinating diseases. She's a graduate of Harvard University and received her medical degree from McGill University. In 2009, she founded the Neurology International Residence Video Conferencing Exchange, which has the acronym NIRVE, NERV, and now serves as the faculty mentor to this neurology education program, which connects neurology residents across 5 continents for regular interactive educational sessions. And of note, Dr. Rotstein first learned about MS when her grade 7 class participated in the MS Society's annual readathon. So there you go, the power and lasting influence of our readathon program. So please join me in giving a warm virtual welcome to Dr. Rotstein.
Thank you all for joining us today. And thank you to the MS Society of Canada for supporting this talk. I'm Dr. Dalia Rotstein, and I'm going to be speaking to you about MS in immigrants, effect of the Canadian environment on the risk of developing MS. So this research was sponsored by the MS Society of Canada and the CMSC, and there are the rest of my disclosures. So we're going to start today by describing the global distribution of MS. Then we will discuss the goals of migration studies in MS. We will then explore how MS risk compares in immigrants to Ontario versus those who grew up in Ontario. We'll identify some risk factors for developing MS in immigrants. And lastly, we'll discuss why Canada is such a particularly high-risk environment for developing MS. So here's a map of the global distribution of MS. Now, we've all become very familiar this past year with different maps of disease, mostly in the context of COVID-19. But with respect to MS, we can see a striking disparity in the rates of MS around the world. We see very low rates of MS in Africa and East Asia, so around 5 per 100,000. And then we see very high risks of MS in North America and Northern Europe. And Canada is known to have one of the highest rates of MS in the world, more than 200 per 100,000, and that's rivaled only by countries in Northern Scandinavia. And these are very up-to-date numbers that come from the 3rd edition of the Atlas of MS, which was published in September 2020. So how do we explain the global distribution of MS? Well, one of the oldest theories goes back to the 1920s, which was that a latitudinal gradient explained the world distribution of MS. And this refers to the fact that there are higher rates of MS as you get to higher distances away from the equator. But it wasn't known for many years why that was the case. And then around 1960, it was suggested by Atkinson and colleagues that that could be due to sunlight, that sunlight could be the critical factor, with lower exposure to sunlight being associated with a higher risk of MS. And then over the last 20 years, there has been an accumulating body of evidence to suggest that vitamin D deficiency is associated with a risk of developing MS. And we know that in warmer climates, individuals get most of their vitamin D from sunlight, from ultraviolet B radiation in sunlight that's absorbed in the skin and then converted to the active form of vitamin D. So sunlight exposure and vitamin D may be related to each other, but they also may be independent risk factors. Another long-standing theory to explain the global distribution of MS is a hygiene hypothesis, although this has been largely disproven. And the hygiene hypothesis refers to the observation that there's a higher rate of MS in wealthier countries. It was thought that in countries that were relatively less affluent, there could be exposure to certain viruses or other antigens in the early years that might prime the immune system in important ways. And we know that MS is an autoimmune disease. So we haven't been able to show that there are viruses that might be linked to the risk of MS, except for infectious mononucleosis or the Epstein-Barr virus. And we do see that in countries where individuals get infectious mononucleosis or Epstein-Barr virus at later ages, so in their later teen years or early adulthood, they do seem to have a higher risk of developing MS. We also know that the latitudinal gradient does not explain the risk of MS every place in the world. There do seem to be some important exceptions. So for example, Japan is at a relatively high latitude, but has a relatively low risk of MS. And we think there may be protective genetic factors at play in that population. And we also observe genetic founder effects in certain populations. So for example, the island of Sardinia in Italy has a higher risk of MS than the rest of Italy, and that's thought to be due to a genetic isolate effect. So now we're going to take a brief walk through history and discuss some of the early immigration studies. And there's a long tradition of immigration studies in the MS literature, which can help us to isolate the importance of environmental factors instead of genetics in determining risk of MS. So one of the oldest studies dates back to the early 1960s by Alter and colleagues, and they looked at the risk of MS in immigrants to Israel. And they observed that immigrants from Northern Europe had a much higher rate of developing MS than native Israelis and immigrants from Northern Africa. And then another seminal study was published by Dean and Kurtzby in the early 1970s, and they looked at the risk of MS in immigrants to South Africa. And they found that immigrants from the United Kingdom had a much higher risk of developing MS than those who grew up in South Africa. And they also looked at age of migration as a risk factor for MS. And they found that the immigrants from England who arrived in South Africa before the age of 15 ended up having a relatively lower risk of MS, similar to those who grew up in South Africa. But those who came from the United Kingdom after the age of 15 maintained the higher risk associated with the United Kingdom, their region of origin. And those findings came to form the basis of some tenets that have really been held to be sort of the conventional wisdom in MS epidemiology for many years, but that we have recently challenged. One of these principles is that MS is a disease of white Northern Europeans and their descendants. And this was really held to be a key principle for many years. And when I was going through my neurology training about 10 years ago, I was told that if you see a non-white patient who has symptoms or an attack that would normally be considered relatively typical for MS, you should think twice and you should actually think first of another disease or diagnosis. But that has since been disproven. So we appreciate today that MS definitely can occur in non-whites, particularly here in Canada. And another basic principle was that immigrants who migrate before age 15 take on the risk of their new country of residence, but after age 15, they maintain the risk of their region of origin. And that has also been disproven, as we're going to discuss during the talk. I think we can glean some important insights from studying MS in immigrants. So firstly, these studies help us understand risk factors for developing MS, both environmental and genetic. Secondly, they allow us to identify whether there is a critical age window for environmental exposures that lead to MS. Thirdly, we can identify those populations that are at highest risk and target educational initiatives and resource distribution accordingly. And lastly, they allow us to explore whether immigrants with MS may experience unique challenges that physicians and also their family and friends should be alert to. So I was involved in a large study of MS risk in immigrants to Ontario, and I'm going to walk you through some of our goals. So our primary objective was to describe the risk of MS in immigrants to Ontario and compare that to the risk in long-term residents of Ontario. And then our secondary objectives were first to investigate characteristics that may affect MS risk in immigrants, including country of origin, the age of migration, socioeconomic status, and comorbidities, which means other medical conditions. And we also sought to describe whether health system access and special needs might be unique in the immigrant population with MS compared to others who have MS. So this study took place here in Ontario, which I know you're all familiar with. So Ontario is the most populous province in Canada with a population of more than 13 million. And we have a very large and multiculturally diverse cohort of immigrants, with more than 2.5 million having arrived since 1985. So for this study, we utilized the electronic database of Citizenship and Immigration Canada, which went back to 1985. So we weren't able to access the data of immigrants who arrived before that date, but it still allowed for a very large cohort of immigrants. And this was the largest study to date, including all other countries in the world, of MS in immigrants. We had more than 1,500 new cases of MS, which we identified in the immigrant population. And why is it important to focus in on MS in immigrants? Well, we know that many immigrants arrive in Canada seeking out a better life. And it is very unsettling, that immigrants who come here to achieve a better life then develop, this chronic and debilitating disease, which probably is in large part due to the Canadian environment. And I think it behooves us to help, this special group of people with MS in any way we can, particularly where they don't have the same support structure that many other people with MS do. So here's another map showing where the immigrants to Ontario hail from. This was from another study from the cardiology literature, but you can see highlighted in dark brown the countries that have the greatest number of immigrants to Ontario. So we see Russia, the United States, China, several countries in South Asia and the Middle East, and then several countries in Europe. So we're going to move on now to our findings. Well, we did observe a lower risk of MS in immigrants compared to the long-term residents of Ontario, and that wasn't surprising because we know, as we said at the outset, that Canada has one of the highest rates of MS in the world. And now I'm going to walk you through the different risk factors for developing MS in the immigrants that we analyzed. And I appreciate that this table is a little busy and that the numbers are quite small, but I'll be reading them out to you. So the first risk factor that we analyzed was the age at landing. Now, in the past, many of the studies analyzed age at immigration in sort of a simplistic manner. So once this idea came out that age 15 was a critical threshold for MS risk, most of the studies just cut the data in terms of individuals arriving before age 15 and then immigrants arriving after age 15. And the reason for cutting the data in that way was largely due to small numbers. But in our study, because we had a far larger number of immigrants who developed MS, we were able to analyze age at landing in a much more nuanced way. So we looked at several different age categories. And here, if the hazard ratio is greater than 1, it means a greater risk of developing MS. And where the HR or hazard ratio is less than 1, it means a lower risk of developing MS. So for age at landing, our reference category was age under 15, and we saw that those who were in the age group from age 16 to 30 had a 27% lower risk of developing MS than those who arrived at age 15 or less. So there was a drop in MS risk as we looked at immigrants of older ages, but it wasn't this dramatic drop in risk after age 15. And that implies that the Canadian environment can still exert an influence on MS risk into adult exposures. And I think that's an important observation. We also saw that female gender was associated with a higher risk of MS, and that is observed across all populations with MS. We know that autoimmune diseases in general are more common in women. And then we went on to look at region of origin as a risk factor for developing MS, and we saw dramatic differences in MS risk by region of origin. So in East Asia, the risk of developing MS was 85% lower than the reference category, which was immigrants arriving from Western countries. However, in immigrants who arrived from the Middle East, we saw a higher risk of developing MS. And I think that speaks to the importance both of early life environmental exposures and also of genetics as two factors that do help contribute to risk of developing MS. We also looked at the weighted ADG scores, which is a measure of the number of other medical conditions an individual carries. And we saw that the risk of developing MS was increased when individuals had a higher number of other medical conditions. And we're going to be discussing that more a little bit later. And lastly, we analyzed how risk might vary with the duration of the immigrant's residence in Canada. And we saw a higher risk with longer times spent in Canada, again, speaking to that very high risk effect of the Canadian environment. So here we broke down the risk of developing MS by country of origin. In the previous slide, I showed you region of origin. And the bars that we see to the right here imply a greater risk of MS compared to a reference category of the United Kingdom. And then to the left, we see countries that had a lower risk of MS in immigrants compared to immigrants from the United Kingdom. And the asterisks signify an effect that was statistically significant. So we see a significantly higher risk of MS in those who arrived from Iran, Lebanon, and the former Yugoslavia. I think it's interesting to observe that these are all former conflict zones, and it may lead us to ask whether there could be, a certain toxic exposure associated with warfare, or perhaps psychological or physical trauma that might be driving influence on MS risk in those populations of immigrants. We also saw a higher risk of MS in immigrants from the United States compared to immigrants from England. And then we saw a much lower risk of developing MS in immigrants from various countries in Southeast Asia and also from China. And there was a previous study in Norway where they also looked at risk of developing MS by country of origin, although this was a smaller study with only 236 cases of MS in immigrants. But they identified some of the same trends in terms of higher and lower risk countries. So again, they saw that immigrants from the former Yugoslavia and Iran, for example, as well as from Northern Europe, had a relatively higher risk of developing MS. And then immigrants who arrived from several countries in Southeast Asia and Africa had a lower overall risk of MS. So the novel findings from our study were firstly that we did not observe any cutoff age for susceptibility to the Canadian environment. We did see that MS risk increased with duration of Canadian residence. And we saw a particularly high risk of MS in those who arrived from the Middle East, Europe, and the United States. And lastly, comorbidity or other medical conditions were associated with risk of MS. And a little bit later, we'll look at which individual medical conditions were associated with risk at MS diagnosis. So I think second generation immigrant studies can also provide some important insights. And we haven't looked at that here in Canada yet, but I am interested in doing so in the future. This has been investigated in several Scandinavian countries, including Denmark, Norway, and Sweden. But basically, we know that genetic load is really relatively constant from one generation to the next because evolution operates on a much longer time scale. So when we see a dramatic jump in MS risk from immigrants to, the second generation or their children, that implies a primary influence of environmental risk factors. And in fact, that was what was observed in the second generation immigrant studies in Denmark, Norway, and Sweden. So they looked at groups, where the parents had quite a low risk of developing MS. So the parents were immigrants from Southeast Asia, and they found a much higher risk of MS in the second generation. In Denmark, they identified high risk in second generation immigrants, particularly from Pakistan, where their risk was even higher than that of ethnic Danes. And in Norway, they saw a similar effect with second generation immigrants from Pakistan having a markedly higher risk of developing MS. In Sweden, they observed that male immigrants in the second generation from Iran had a higher risk of developing MS than native Swedes. So again, this reinforces the primary part of environmental exposures in MS risk. So what role, what role does genetics play? Well, there have been many studies that have helped to establish this, and this is kind of a summary slide that was taken from healthline.com. In my practice, many of my patients ask me what the risk is that their child or their sibling is going to develop MS once they have the disease. And hopefully this is relatively reassuring. So the study suggests that if you have a parent or sibling with MS, you have a 1 to 3% chance of developing the disease. So that is quite a low risk overall, although it is a little bit higher than the risk in the general population. And classically, the type of study that's done to determine whether a disease is largely inherited or not is the identical twin study. So we know that identical twins have 100% the same genes or DNA as each other. So in a perfectly inherited disorder, if one identical twin has the disease, then there is a 100% chance that that other twin will develop the disease. But when identical twin studies were done with MS, the finding was that there was a 30% risk of developing MS in identical twins. So, that is still substantial, and it does imply that genes play some role, but that the majority of the risk is determined by the environment. So why is a Canadian environment so high risk for developing MS? Well, we know that we have, relatively low sunlight exposure here compared to countries with warmer climates. And we also know that with less sunlight exposure often comes vitamin D deficiency. And I'm going to show you a slide in a minute to explain that. Another critical factor that may be changing over time in immigrants is that their diet may change after their arrival in North America, where we know that we often have dietary patterns that are higher in fatty foods, and the availability of different foods, may contrast with the country where they come from, and that may lead to obesity. And there are several studies that suggest that obesity increases the risk of developing MS. And there may be other reasons that explain why the Canadian environment is high risk that we simply haven't discovered yet. And I think it is important that we continue to do research in this area. So here's a slide to explain how most people get their vitamin D. Well, in warmer climates, all of the daily requirement of vitamin D can be quickly obtained from sunlight exposure. So we have ultraviolet B radiation from the sun, which is absorbed into the skin. And then we have a vitamin D precursor in the skin that then travels to the liver. It is converted to 25-hydroxy vitamin D. It moves on to the kidney, where it becomes the active form of vitamin D, or 1,25-dihydroxy vitamin D. And we know that in warmer climates, the effect of whole body exposure to the sunlight for 20 minutes is that we get more than 10,000 units of vitamin D, so much more than the daily requirement of vitamin D. But in colder climates, such as here in Canada, we're left with obtaining a lot of our vitamin D, either from dietary sources or from supplements. And most of our dietary sources of vitamin D are not particularly rich. So milk, yogurt, and other dairy products, for example, have some vitamin D, but that's on the order of about 80 to 125 international units. And then egg yolks have a little bit of vitamin D, but only about 40 international units. Really, the richest dietary source of vitamin D is fatty fish. So salmon, for example, has close to 500 international units of vitamin D. And cod liver oil has 1360 international units of vitamin D, but most of us aren't taking down cod liver oil by the spoonful. Interestingly, it's thought that one of the reasons why the Inuit population of Canada might have a much lower risk of MS than the general population, which is what we've observed, is due to their diets, that they have a diet that's actually quite rich in fatty fish. So here are the recommended daily vitamin T intake guidelines, which were developed by the MS Society of Canada. So you can see that the recommended daily intake does vary by age, but for individuals aged 9 to 70 years old, it's recommended that people consume or acquire at least 600 international units of vitamin D. And for those with established MS, I usually recommend, and many of my colleagues recommend, closer to the maximum daily intake level of 4,000 international units. And the reason for that is that there have been various studies in those with established MS showing that maintaining higher levels of vitamin D can be protective against new attacks and also protective against the accumulation of physical disability in MS long-term. And just a couple of tips. One is that supplements and fortified foods should be taken with a meal that is high in healthy fats, which aids in the absorption of vitamin D. And beyond consuming your vitamin D supplement with food, you can take the vitamin D at any time of day. So we spoke a little bit before about how diet and obesity may affect the risk of MS. There have been various studies demonstrating that, but I just wanted to show one to you. This was a genetic study. So it was a very large cohort, and basically the authors, the investigators identified genes that led to obesity. And they saw that individuals with a high load of these genes that lead to obesity also had a much higher risk of developing MS over time. And there have been various other studies linking obesity with the risk of MS, although the evidence seems to be stronger that obesity in late childhood and early adolescence is associated with MS risk. So it's not quite as clear cut whether adult obesity is associated with risk of developing MS, but we expect that there will be more research in that area in coming years. So how might obesity affect risk of MS or other autoimmune diseases? So this is just kind of a quick summary slide, but this can occur in different ways. So one is that the adipose tissue or fatty tissue seems to drive pro-inflammatory immune cells, including the Th17 cells. We also know that some of our regulatory immune cells, such as the macrophages, are reduced in the context of obesity. And as a result, you can have greater formation of autoantibodies. Obesity itself seems to be associated with higher levels of the Th17 cells or pro-inflammatory cells, even independent of these other effects. We know that obesity is also associated with vitamin D deficiency, and vitamin D has many important immune effects in the body, including helping to regulate antibody production and also some of these T cells, which are pro-inflammatory. And lastly, we know that the consumption of fatty foods has effects on our gut microbiome. And the gut microbiome refers to the billions of different microorganisms that exist in our gut and help with the digestion of food. And we know that there are unique microbiome signatures in individuals who have autoimmune diseases. And the different microorganisms in our gut probably also contribute to regulation of these different immune inflammatory cells. So what can we do here in Canada to lower our risk of MS? Well, one, we can enjoy the sun safely. So, of course, after a certain number of minutes, about 20 minutes in the sun, you should make sure you are using sunscreen. But so we do think that sunlight exposure is an important contributor to MS risk. I think, it can be challenging to get all of the vitamin D we need from our diets. So taking vitamin D supplements can be quite helpful. Lastly, we haven't discussed this, but smoking is another important risk factor for developing MS that's been identified. So you can avoid secondhand tobacco smoke, or if you're already a smoker, you can try quitting smoking. And lastly, we think that eating a healthy diet and maintaining a healthy body weight is also a contributor to the risk of developing MS. So we looked at different medical conditions associated with MS risk in our immigrant cohort. And we did find that there are probably that many conditions were more common in immigrants at the time of MS diagnosis. And the same conditions have been shown to be more common in the general population with MS as well, compared to those who don't have MS. And there are probably some common risk factors to these conditions and also to MS. So for example, we saw a higher prevalence of certain conditions that are associated with obesity, such as diabetes and high blood pressure and ischemic heart disease in immigrants who developed MS. We also saw a higher rate of COPD, which is a lung condition associated with smoking in people at MS diagnosis. So some of these effects may be due to common risk factors. Another interesting observation is that we saw higher rates of other neurologic diseases in immigrants at the time of their MS diagnosis compared to the rest of the immigrant population. So we saw a higher rate of epilepsy or seizures, and we saw higher rates of migraine headaches and also of mood disorders such as depression in the immigrants at their time of MS diagnosis. And we know that there may be a prodromal phase to MS. So there have been several studies showing this in recent years, that there are actually several symptoms that probably precede the first attack of MS by several years. And identifying these conditions early perhaps could facilitate earlier diagnosis of MS. We also think that early identification of other medical conditions can be key to improving the course of MS long-term. So if these conditions are identified and treated earlier on in the disease, we know that they can lead to worse outcomes in people with MS over time. So we may be able to help people, both the general population with MS and also immigrants with MS, control their disease by identifying these conditions earlier on. We wanted to look at other issues around access to the healthcare system in immigrants with MS. So we look broadly speaking at, access to outpatient care and also to hospital admissions. And generally, we saw that immigrants with MS had similar or lower use of the healthcare system than long-term residents with MS. But one particular issue that was identified was that in the year of diagnosis, we did observe a higher rate of hospital admissions in immigrants compared to non-immigrants with MS. And I think that suggests that the year of diagnosis may be a particularly vulnerable time for immigrants with MS, and they likely need extra support during that time. We don't know exactly why that is the case. It could be due to having a more severe first attack of MS, or it could be due to a lack of social supports in Canada. But either way, I think, it behooves physicians and also friends and family of immigrants who have MS to pay particular attention to them during that first challenging year after the MS diagnosis. So we looked at mortality as well in immigrants with MS, and we saw a similar pattern. So here a higher hazard ratio means basically if it's greater than 1, it means a greater risk of death. And we saw a greater risk of death associated with, several risk factors we see in the general population. So a higher risk of death in men versus women, and higher risk of death in those with lower socioeconomic status. But one unexpected finding was we saw a higher risk of death in immigrants compared to non-immigrants in that first year of diagnosis. Again, just highlighting that this seems to be a particularly vulnerable time for immigrants with MS, where they likely need extra supports. We saw a lower risk of death in the immigrants once they got past that year after diagnosis, but that is not wholly unexpected because of the healthy immigrant effect. So this is one important aspect to be aware of, that immigrants tend to be healthier, wealthier, and better educated than the general population in the country from which they emerge. So that's also just a caveat in terms of interpreting rates of MS in immigrants from a certain country. We can't generalize that risk, to the MS risk in their native country. Another important aspect to think about is whether this critical age window for exposure to different environmental factors that may drive MS may depend on the particular risk factor involved. So perhaps some of the differences we observed in our research compared to the older studies may be due to the individual risk factors investigated. I think it is important to try to account for various risk factors for MS in these studies. And depending on the study, there are limitations to the data sources. So in the future, when we do additional research into MS risk in immigrants, we would like to control for known risk factors for MS, including the vitamin D status, obesity, smoking, and race. And these factors may help to clarify the reasons why we see such big jumps in intergenerational differences in MS risk. And lastly, genetic and epigenetic studies, I think, can provide important information in the immigrant population that can help us predict risk in family members, for example, of people who have MS. And epigenetics refers to the phenomenon by which environmental factors and genetic factors can directly interact. And there has been growing research in that area in recent years. So just to summarize, we know that Canada is a very high-risk environment for developing MS. We've seen from our immigration studies that MS is a risk for all those living in Canada, no matter what their background. We know that there are certain risk factors for developing MS in immigrants, and they can help us target educational initiatives and interventions to higher risk groups. And these include origin from the Middle East or the Western world, including Europe and North America. Younger age migration is also a risk factor for developing MS in Canada, female gender, and the duration of exposure to the Canadian environment. There are also some important strategies for reducing risk of developing MS, which include sunlight exposure, vitamin D supplementation, quitting smoking, and maintaining a healthy body weight. So I'd also like to acknowledge my collaborators in this research and our funding sources, including the MS Society of Canada. And thank you all for your attention. We now have time for any questions.
Wow, amazing information. Thank you so much, Dr. Rotstein, for that. So many takeaways from what you've presented. Just a few notes I've made before we get into questions. Just really the importance around the first year of diagnosis of some immigrants and how particularly vulnerable they may be at that time, and therefore the importance of ensuring added support to folks at that particular time. The list of involved factors that you noted, which may have a bearing, such as age of landing, female gender issue, area of origin, risk, increasing duration of time in Canada conflict zones. Also, this intergenerational consideration and genetics and genetic isolation and those impacts. So much information that you've provided. I'll just say to people on the call that we now have time for some questions. And if you haven't already, to please type your question in the message or question box at the bottom of your slide. And while waiting for people to perhaps provide some additional questions, I have a couple, Dr. Rotstein, for you. So fascinating work examining really immigrant origins around the world. So what have you enjoyed the most, would you say, during the research in this particular subject area? And what have been some of the challenges for you?
Sure. So thank you, first of all, so much for having me today. And thank you to the audience for your attention. Yeah, I think that's a very good question. I mean, I think one aspect I enjoy about research in general is just the opportunity to work with a team of people, and we all bring, different strengths to the table. I do think we have a really unique opportunity to study this issue here in Canada. I think it's very important to look at risk of MS and also how MS plays out in people of different ethnic backgrounds and different regions of origin. Of course, here in Canada, we have the advantage of centralized health records and also universal health insurance. So we have a unique opportunity to look at this that doesn't exist other places. We also have, our very rich and multicultural society. So we also, can investigate how people of various backgrounds can, how their MS plays out and what their risk of MS is. So I think we have something to bring to the table. I think it also has, a very important practical impact in terms of clinical care. So we know that there are many countries where people have never heard of MS, perhaps to some extent because it's less common, but also because it's under-recognized. But when they arrive here in Canada, their risk of MS may increase. And I think that it behooves us to provide education. Physicians need to be aware that MS can occur in people of non-white background and do the appropriate investigations. So I think it's very important from an educational perspective. And then, as you pointed out, we've seen that first year after diagnosis is a vulnerable period for immigrants with MS. So by being aware of this, we can offer immigrants extra support during that time.
Terrific. Thank you so much for that. I have a question from Darcy from Toronto. Great question. What form of MS is more prevalent in immigrants with MS? Doctor?
Sure, that's a very good question, and I don't have a definitive answer for you. So you may know that there are different clinical forms of MS. So the majority of people have relapsing remitting MS at the time of onset, which is marked by sort of these discrete attacks where symptoms increase over a few weeks and then they stabilize and then they usually improve. There's another form of MS, which is less common at the time of onset, where people have sort of slowly increasing and accumulating disability in the absence of attacks. And that affects about 15% of people with MS at the time of onset. It might be that primary progressive MS could be overrepresented in certain ethnic populations or in certain populations based on the environment that they grow up in. Unfortunately, our health administrative data, so our centralized data, doesn't have coding to allow us to analyze primary progressive versus relapsing remitting MS. But that is something we could look at in the context of individual MS clinics, and I think it is a worthwhile question. I can tell you that when we look at global studies of MS, so studies from different countries, they do report similar rates of primary progressive versus relapsing remitting onset of MS. So our hunch is that the distribution is similar across people of different regions of origin and different ethnic backgrounds, but I don't have a definitive answer for you.
Great, thank you for that. Here's a question from Jessica from Vaughan, Ontario. Is there an increased risk of developing MS for immigrant women who've had children versus women who have not had children? Doctor?
That's another excellent question. Wow, we have some very hard-hitting questions today. And in fact, this predicts another area of research we're looking into. So some of my collaborators and I are hoping to study this using the Ontario data over the next few years. We do know that in the general population, there does seem to be a protective effect of pregnancies on the risk of developing MS. So women who have had previous pregnancies tend to have a slightly lower risk of developing MS. That may be true in immigrant women as well, but we haven't been able to investigate that. And I think that is definitely a worthwhile question for future research.
Excellent, thank you for that. Another question, you talked about some areas of future research, Dr. Rotstein. If there was one particular area of research into the future that you'd like to explore from the number that you've mentioned, what might that be, or what might a couple of areas of particular focus be going into the future?
Yeah, so I think, one important aspect of MS that we've realized over the last few years is how important early diagnosis is. We know by instituting disease-modifying therapies earlier on, we achieve much better outcomes for people long-term. There has been a lot of attention in the last couple of years on this prodromal phase of MS. So now we recognize that the symptoms of MS may actually start years in advance of the MS diagnosis. And that may be because there are other symptoms that kind of give a first clue that something is awry in the immune system in the body. But it could also be just because perhaps MS presents in a more subtle way and it is missed early on. So I think that is a very important area of research. I'd like to delve into in more depth. We may be able to investigate that in the immigrant population as well. Like I said, there are some clues that these immigrants who develop MS have a lot of other medical conditions at the time of their diagnosis, which perhaps could provide early signals that they are at greater risk. Another focus of my research is trying to differentiate MS from other demyelinating conditions. So there are some other more rare types of demyelinating conditions, such as neuromyelitis optica. And we think that neuromyelitis optica could have its own unique prodrome or signature. And by recognizing that, we may be able to differentiate different types of demyelinating conditions earlier on, and then get people started on appropriate therapy earlier as well. So the main goal ultimately is just to try to achieve better quality of life and better outcomes for people with MS. And I think we're on our way.
Yeah, lots more research that's required to deal with some of the findings you've presented to us. Just so much more to understand. Here's a question on vitamin D, Dr. Rotstein. Have your studies looked at vitamin D metabolites from sun exposure and their potential modulatory effect on the immune system? Dr. Rotstein?
Sure. Yeah, that's another excellent question. I haven't looked at that myself because I do clinical research, so I don't do basic science research in the lab. But there are other labs and people in Canada investigating that. There was some very interesting work recently out of the Montreal Neurological Institute from Luke Healy's lab, and they found that vitamin D may affect phagocytosis and in that way may contribute to the potential for remyelination and neurologic repair. So I think there is a lot of fascinating work being done on that front.
Okay, thank you. It's a question on COVID, and we're all facing the realities of COVID in our own ways. But how have the current realities of COVID-19 impacted the way you work and your team is working, and is that impacting the pace of progress in areas that you're trying to examine?
Sure, it's a big question. It's obviously a question on all of our minds. It's kind of a fascinating time in terms of how COVID has affected us. I think there's sort of been a yin and a yang in terms of what I see in my clinical practice. I think there are cases where it's hard to do virtual care, especially if a patient has a change in their medical condition. In those cases, it's very valuable to see somebody in person. Many people with MS are worried about coming into hospital and COVID exposure, although I'd like to reassure people that, we screen at the doors of the hospital and we're practicing physical distancing. So I think if you do have a change in your symptoms, it's very important to connect with your neurologist and, try to get an in-person assessment. But on the other hand, I've seen some benefits for my patients with MS. So many of them have enjoyed the more flexible arrangements of this time, such as working from home. It's allowed them to focus more on their quality of life, whether it's getting out for regular walks or doing an exercise program at home. And I think some people, where their symptoms are stable, can benefit from doing a virtual visit. There's a convenience factor to that. I think that it has built in more flexibility in terms of how we think about delivering medical care and how we can offer that in the future. So that those are definite advantages. On the research front, unfortunately, COVID has stalled some research in terms of in-person research studies and clinical trials because, of course, our foremost concern is just to keep our patients safe during this time and to avoid any unnecessary in-person exposures. But, research is still ongoing. So, for example, some of the research I do is through the databases using the OHIP data in Ontario, and that research can still go on. And I think, even more research will get off the ground as we slowly come out of the pandemic.
Great. Well, it's great to hear you speak of some of the advantages, the opportunities, progress forward despite COVID-19. It's good to hear there's a silver lining relative to your research program. Question here from Patricia. Has MS been found to contribute to premature births, Dr. Rotstein?
Yeah, a number of questions today about pregnancy, and this is actually an interest area of mine as well. So to date, there have been multiple studies, and it doesn't seem, fortunately, that MS contributes to premature births. And overall, it doesn't look like there are any sort of increased risks around pregnancy and delivery in women with MS compared to the general population, which is very reassuring. I'd say the only signal that has come through across different studies is that women with MS may have babies of slightly lower birth weight. So that is one signal, but otherwise it doesn't seem like other, conditions like premature birth or complications of delivery are increased. I have to say, though, again, we have a unique opportunity to investigate that in Canada because of our large centralized data sources. And I am hoping to do that in the next few years with some collaborators, as to date, a lot of the data have emerged out from other countries.
Thank you. Are there any other questions? Just please type into the message box at the bottom. Oh, there's one from Maria. Thanks, Maria. Do you have any data on Hispanic population, Dr. Rotstein?
Yeah, this is quite interesting. Of course, we have smaller numbers of Hispanic individuals here than in the United States. So much of the data on this topic has come out of the United States. There have been several studies over the last year or so. I think in general, what they've found is that Hispanics have a slightly lower rate of developing MS compared to the white population. However, in people who do have MS, non-whites sometimes seem to have a more aggressive course of the disease or earlier development of disability, and that has been observed in the Hispanic population in the United States. And the reasons for that are not that well understood. So it's not understood if there could be underlying pathologic differences in the disease. There could be differences in responses to some of the therapies we use, or it could be due to, lesser access to healthcare, for example, in the United States, where, private versus public health insurance is more of an issue. I do think, that's a very important subject to research as well in coming years.
Great, thank you. And that question from Maria was from her location in Mexico.
Okay.
Any other questions we can pose to Dr. Rotstein? We have just another couple of minutes. Okay, well, Dr. Rotstein, thank you so much for your great presentation, for joining us here today. And I want to thank everybody for, oh, I'm sorry, we do have a question just came in. Do you have a greater risk for MS if someone in your immediate family has MS?
Yeah, so the answer is yes. That we see a 1 to 3% risk of MS when there is a first degree relative affected, like a parent, a sibling, or a child. So I think family members of somebody with MS should be aware of that, and there are some strategies they can adopt to try to lower their MS risk long term, like getting that sunlight exposure, eating a healthy diet, and supplementing with vitamin D. Overall, though, although the risk is a little bit higher, it still is low. So hopefully that is reassuring to people. And there are steps you can take to help lower that long-term risk of MS.
Okay, thank you for that. Is there another question? Yes, we do have one. Is there a risk factor, Dr. Rotstein, for people with MS to contract COVID more easily or have a more severe outcome?
Another great question, and certainly one, that we were asking over the course of the last year. Initially, we didn't have any data to inform us, but there have been groups studying this in different countries around the world. So I can tell you with relative confidence at this time that we don't see any increased risk of COVID in people with MS, and we also do not see any increase in severe outcomes in people with MS. There are some risk factors for more severe COVID that are similar to the general population. So older individuals with MS, those with greater physical disability at baseline, and those with obesity or higher, body weight seem to have a higher chance of getting severe COVID. But that is the same as the general population.
Right. Thank you. Yeah, we had a wonderful webinar about two months ago. The MS Society led that, and exactly the same some comments and findings as you reported on that. Okay, so I think this is maybe our final question. Do your findings from this work extend into risk of disease progression and relapse rate for those that already have MS, Dr. Rotstein? It's from Julie.
Yeah, another excellent question. So in this work, we did not investigate those who already had MS, but that certainly is of interest. And some other investigators at my center at St. Michael's Hospital in Toronto have looked at this in the context of our clinic population. Interestingly, they found that individuals from the Middle East and Northern Africa who developed MS seem to have I think a higher risk of more severe disease compared to the white population. And now we're looking at that in Black individuals with MS in our clinic population to see if they also might have more severe disease. The long-term objective of these kinds of studies is to help us personalize our approach to therapy. So if we know that there are certain risk factors for more severe MS, we can tailor therapy earlier on. We can take a more, aggressive approach to disease-modifying therapy. We can also study whether certain environmental risk factors might be linked with more severe MS. So for example, like, the diet, the sunlight exposure, or vitamin D. And then we can give advice to our patients about how to modify their lifestyles accordingly.
Terrific. Okay, we're going to squeeze one more question in. This is from Mark from Milton. We had a wonderful presentation on some of this yesterday. Can you elaborate further on the correlation between depression and stress and other psychological issues on the development of MS?
Yeah, so this area of research is still in its infancy, but I think it is of a lot of interest. I don't know if I sort of mentioned it in passing that stress could contribute to risk of developing MS. There was one large study out of Scandinavia that showed that that somebody who had lost a family member was at greater risk of developing MS, and the suggestion was that the psychological stress might contribute to developing MS. There are other studies, though, that do not show a link between psychological stress and the risk of developing MS. I think the jury is still out on this question, but it does merit investigation, in the future.
Okay, terrific. Thank you. I think that's all the time we have for questions today. And thank you again, Dr. Rotstein, for being here and for your presentation. And thanks to all of you for joining us.
Thank you so much for hosting, and thank you to the MS Society for sponsoring this event, and to our audience members for their attention.
Thank you. I have a few additional comments in just a minute. So I'd like to say a special thank you to our sponsors for making this event possible. Thank you to our lead sponsor, Bristol Myers Squibb, and contributing sponsors, Abbey by Biogen, Novartis Pharmaceuticals Canada, and Roche Canada, for providing the financial support to make this online conference possible. I also encourage you to go to the MS Society's website if you'd like to learn about our programs, services, research, or becoming a volunteer. We have a remarkable service with the MS Knowledge Network, as most of you will know. It's a hub of knowledge staffed by our amazing MS navigators who are available to answer your questions every weekday from 8 a.m. to 8 p.m. by phone, by email, or live chat in both English and French. They can provide you with consistent, quality MS information and support. There's also support available for anyone experiencing an MS-related challenge through our one-on-one peer support and one-call programs. You can find out more at the mssociety.ca site. You can also celebrate MS Awareness Month with us by taking part in the second annual virtual carnation pinning on May the 5th. You can take action for MS site and show your support for MS community by sharing on social media at that hashtag. I hope you'll also join me and tens of thousands of people across the country for MS Walk on May the 30th, which is taking place on World MS Day this year at the same time. We'll all be walking in our own neighborhoods across Canada and connecting online to show that no one with MS is alone. And you can find out more at mswalks.ca. Last but not least, I'd like to thank each and every one of you for investing your time and learning more about MS and MS research. All of the MS Connect sessions are being recorded and will be available for viewing at a later date at msconnect.ca. So please join us later today for the strength and stretching exercise class and the Ask the Expert panel discussion with information about nutrition, exercise, and mental health. Thanks again, everyone. Have a great day.